Hello again, and welcome back to Parenting Stuff I Wish I Knew Sooner, and I Want You to Know Now. I'm your host, Erica Jesper, founder of the Center for Confident Parenting, and a mom who has seemed to learn everything I needed to know the hard way. My guest today, I'm super excited, is Dr. Maria Cordero. She is mom to two young children, ages 4 and 8, a board-certified pediatric dentist, and the owner of Philadelphia Pediatric Dentistry. Just as a side note, she's also a biomedical engineer. So that's Dr. Maria. Thank you for joining me.
Thank you so much for having me, Erica. I, as you know, love talking to you. Could go on for hours.
I was just kicking myself for not recording our prep session because we were cracking up and it was super fun. And we'll have to come back and do a fun podcast later. While we're on the topic, remind me, biomedical engineer, like what's going on with that? I feel like I'm in the presence of greatness and I'm suddenly intimidated.
Well, I think a little bit of it is it's my parents' version of wishing they could have learned it the easy way, but learning the hard way, guiding me through how my brain worked. And a little bit of there's so many ways to solve a problem. And you can sometimes look at a problem and go, I think this is how a system works. Or you could look at a problem and say, I believe this is how it works. Let's build a model and test it. And that's how my brain works. And that's all that biomedical engineering really is. It's looking at something beautiful like the body, biology, and saying, I think I understand this mechanism. Let's pull it away from that and let's be able to put it in a lab and do something with it. So you can model how blood flows through your body the way an electrical circuit works. And then you can make decisions on that. So it was a great decision. I am not a PhD in biomedical engineering doing drug research as I thought I was going to be. I am a pediatric dentist and I study how the brains of small humans and their parents come together and make decisions. And you model it in a very similar way. So it's actually a delightful part of my practice every day.
So that is so very cool. Unless I didn't know it, you're the first, biomedical engineer I've ever spoken with, and definitely the first one I've had on the show. So
awesome. Love
but
it.
that is not why we're here today. So first things first, tell us some other things about yourself, your family, and of course, how your pediatric dental practice came to be.
Thank you. Yes. So when I talk about my practice, I always open up with the silly joke of I'm a recovering academic. So that biomedical engineering, that didn't stop. That didn't stop when I went to dental school. I went on, and as soon as I came out of residency, I was like, I want to do so much more than I can with my two hands. So I went straight into teaching in dental schools and residency programs and surrounded myself with people far wiser than my new grad self and stepped into roles that I don't know how I convinced them to trust me but I had to learn so much.
Fake it till you make it.
Exactly. And I also was able to develop ideas in a space where you could just incubate something, where you didn't have to be producing and a business. You could say, I believe this is how it should work. And I understand it hasn't always been that way, but we could do better. And that special incubation of the ivory tower that people talk about and say, oh, well, it only works there. And it's a space that helped me develop a lot of my understanding of nutrition, because traditionally you get a whole 2 hours of that training, right? But I'm very passionate about nutrition. It's a space that gave me a lot of development in behavior, and not just child behavior, because people love to study child behavior, but caregiver behavior, behavioral change, how we take on our decisions. It's a space that allowed me to work with other specialists all the time. So I didn't have to limit myself to the knowledge base available to pediatric dentistry. I had endodontists down the hall, and I was able to learn as they kept updating their techniques and methods and materials. I was in a department consistently with orthodontists, so I could constantly say, I understand you start and do it this way, but what are you seeing now? And I could widen what I saw. So it was just a beautiful first decade. And so that first decade ran straight into the next biggest thing in my life, which was I became a parent. Oh man, that changed everything. That changed
As it
absolutely
does.
everything. Um, and part of what it changed was how I could spend the 24 hours of a day.
Mhm.
And what I realized was, as I was coming through this academic world, in order to meet my goals and my dreams, I had to become a dean. And
Mm.
that's a lot of hours. And there are other ways to be able to have that much contribution. And so that's where I started framing out that I might actually own a practice, open up a practice, because I had a child that I was very committed to walking to school every day. And
Mhm.
it's such a little thing, but the threat to my ability to walk my child to school every day was incredibly motivating.
Mhm.
And I also had a child that taught me what gray meant because I
Mm.
was the best parent ever before I had a child.
Before you had a child, aren't we
Right?
all?
Like, oh my goodness, what I didn't know, but also how much empathy did to the practice that I'm able to offer families,
Because like it's very
understanding it.
academic to say like you need to do a better job with your kids' teeth
Right,
or
it's super academic to
nutrition.
say, "You must stop sucking your thumb, otherwise you're gonna ruin everything."
Right. But
Right.
with no awareness of like the
What
logistics of implementing that can be really
right.
difficult, if not impossible slash overwhelming in like real life.
And what
So
probably just
now you
happened
have
before.
both pieces, right? That's awesome.
Yes. So much empathy and patience, not just for the child, but for families, because each touch point is an opportunity to share, like, okay, where do we need to grow? And I don't have to win, right?
Mm.
I just have to keep showing up and help them get incrementally closer to where they want to be.
Mhm.
And typically, it's also where I hope they should be. That doesn't have to always be the same thing. So I just think that my son has taught me tremendous things that I never would have known in that first decade of very academic pediatric dentistry.
Which is
And
amazing because look at your academic background, and here comes this little tiny human, like, oh, yeah, I'm going to
watch me.
teach you something.
Yes, absolutely. And then you add to it, I'm the parent of two now. I have a
Mhm.
daughter. My daughter taught me that just because you think you are the expert because you have a child, you don't know anything. And
Mhm.
so she's a perfect example where I said, okay, this was hard. Ducks in a row. I've got it round two. And it just wasn't.
And then she arrived, different person than you expected, probably.
Different person. And I just got scrambled across the board. Also, it was COVID, which was a really weird time to
Mm,
have a baby. Um,
absolutely.
and I thought that was really fantastic too. And I have changed the type of practice that I have tremendously as a result of those experiences with my daughter and the people that I met along the way and that I learned so much from. And so you can see a good amount of how I share with parents, how I come up with care plans with families, what I educate myself in, where I put all of my energy has a lot to do with those two parenting steps, looking for what I needed so that when someone comes to me, I have more than what I had.
Oh, that's so beautiful. I love it. We could essentially say it's a family business, right?
It is. I guess that's something to also know. I'm second generation, fully immersed dentist. So my
Oh,
father's a
okay.
dentist, and I grew up in a home dental office. So there is also that nature
Hmm.
where many times you have people who have a dental office that's always a couple towns over from where they live. My office is half a mile's walk from my house.
It's
I am
beautiful.
the opposite of the person who wants to be separate from it. I want to
Right.
see all of my patients when I drop my son off at school. I love it. I love the recognition, that community feel, being part of it, being intrinsic to it, as opposed to needing to clearly separate. This is my work and this is where my safe space is. Now, I have been seen taking my garbage out in pajama pants and no makeup on.
You didn't
And
quite want to
it's,
take it, the community outreach that far.
I mean, it is what it is. This is who I am. You just have to be okay with that. And I am
You
okay with
do.
that. But
Well,
the
and
rest
it
of the time,
almost
I do my hair.
Right? It almost harkens back to, the olden days, whatever we want to call them, when like you did have a little community and someone was the store owner and someone was the dentist and you all crossed
Yes.
paths throughout your days. It's really super cool. I think that's one of the cool things about, you're obviously in the art museum area of Philadelphia. There are still spots that sort of function that way, and I think that's one of them. So that's a great segue. While you're talking about your mission to really like be part of the community and not separate it, I know one of the things that you're super passionate about is community outreach,
Yes.
specifically with respect to nutrition and ensuring that every child, every family has access to healthy food. So, can you tell us a little bit about your partnership with the Food Trust?
Yes, absolutely. I love that partnership. Actually, it was one of the things when you're coming out of academia and you're like, I know what my community service is. I know how I'm contributing to my neighborhood and my city every single day. And you go into a small office where you're just one dentist. I'm one small person. Um, and they gave me an opportunity to still help more. And so, what
Mhm.
the Food Trust does, they have a strong mission of seeking food security.
Mhm.
And so the idea is that not everybody has access to healthy, delicious food, fresh food, um, the varieties that they need. Not everybody knows where food comes from. Not everybody knows which choices are actually the better choices for them. And not everybody has the transportation available or the financial resources available. And when I speak every day to a family and I say, there are sometimes choices and then
Mhm.
the choices that I want you to make more often, right? Not forbidden foods, but not everybody gets a choice. And
Right.
so for me, being able to work with the Food Trust every quarter, we pick a project that helps children in the greater Philadelphia area have those choices. And so it might be like in the fall, we do this wonderful program where we buy lots, like tons of apples, like literally tons. And we go into the school and we have like a seasonally appropriate farming book that we'll read with the kids. The last time we actually sponsored an author who had written a book about black eyed peas. So it's
Awesome.
culturally relevant food,
Mhm.
farming hand in the dirt experiences. And these kids got to read the stories. They got to take this bag of apples home to their families. And we're picking communities that need these things, that maybe haven't seen a farm. They don't get to go strawberry picking like I try to
Right.
go.
And if that sounds
And
crazy to you, like, cool. Like, some of us are quite privileged. So let's
right.
just let's honor that. If you're hearing this and like, seriously, really? A bag of
Yes.
apples? But like, we need to check ourselves and realize that some of us are very fortunate and some of us are not. And
Yeah.
some people's experiences and resources are super, super limited.
One of the cool, so talking about behavior, caregiver behavior, they approached me last year and they said, we would like to supplement SNAP benefits so that
Mm.
a family could get as much fresh produce from a farm market as they would get packaged goods with those same benefits at a corner store. So we
Mhm.
want to see that if we just supplemented enough, can we change their purchasing behavior to take better care of themselves? And I was like, yep, I am here for that. Please let
Right?
me do that. So
All up
we've
in
done that at farmers
that.
markets. We've brought farmers markets to schools. So
Mhm.
what they'll do is the kids will staff the farmers market. So they're learning about commerce. They will bring a farmer so that the kids actually are meeting somebody that
Yeah.
is farming directly and gets to talk about it. And so they'll do like school assembly stuff. And then also it supplements so that farmer can regularly come and offer that food to these families that don't otherwise have access. So it needs cushion to become sustainable, and I get to
Yeah.
be the cushion.
I
I
love
and
that.
and so it sets up infrastructure so it lasts. And then we get to build gardens once a year. That's always my favorite project when they're like, "All right, we have a school that wants to build a green space. Can you sponsor that?" I'm like, "Yes, please. Please,
Yes,
let's do that."
I love it. Well, I will try to link to that in the show notes as well. It's a very beautiful mission. So you and I have obviously met before. We did a video and we were talking just the basics of early oral health. We're not going to
Yes.
dig too much into that today because I want to talk about something different, but I will try to link to that video as well in case you're wondering a lot about what to do with your baby or toddler. But another thing you are quite passionate about, I don't think you do anything not passionately. Is that
No,
true?
not worth
Okay.
showing up for.
Me too. Hey. Is supporting oral health in infancy, which includes the airway. So
Yes.
this is something that may or may not, probably not, be on a lot of parents' radar. It's on my radar just because working with kids who are having trouble sleeping, one of the things I like to sort of watch for red flags for is if anything is affecting their airway.
Hmm.
So let's dig into that.
Yes, I'd love to.
Before we do that, just touch on briefly, like when should parents begin to care for teeth? And
Yeah,
you might modify that. And when do we start taking kids to the dentist? And then we'll get to
great.
the airway stuff.
Yes. Okay. So, one of the most important things to know is as soon as they have teeth in their mouth, everything changes. Your bacteria changes, and you have to take care of them. And so, the bacteria that causes cavities doesn't even show up until there is a tooth.
Mhm,
So, the answer to when do you have to take care of teeth is as soon as it happens.
mhm,
Sometimes we're surprised though. So, what I would suggest is people always talk about, oh, you have to clean the gums. You don't really have to clean the gums, but you should, from the point your baby is born, wash your hands and put your finger in your baby's mouth every day.
mm,
And it seems like you're just like checking off and doing a thing, but you are doing so many things. You are waking up nerve endings,
mm,
activating the tongue, and familiarizing yourself with what normal is. And you will never miss when that first tooth comes in.
mm.
And what I really like about this is we've all had babies who get sick, and then 3 days later, after being a little congested, they get their ear infection. It is a little bit frustrating to go in when you think it's an ear infection and it's just an erupting tooth. This
Yeah.
will prevent you ever going to the pediatrician being like, my kiddo has a fever. They're kind of grumpy. I think they have an ear infection. And then the pediatrician goes, oh, look, they're teething, which, by
Mhm.
the way, I totally did.
Did, of course.
Right? This is a perfect example of please learn. It was just absolutely mortifying and hilarious at the same
Not
time where I
saying
was
you
like,
shouldn't go if you're concerned, but like if you can just see and feel and be like, oh, that's what
yeah.
it is.
It is
Yeah,
so
that's true.
empowering to know when something changes. So, taking
Yeah.
care of your little one's mouth begins by just like knowing it. And so,
Hmm.
touching it, fear not, be there, be empowered by it. And as soon as they have a tooth, you start brushing it with a brush that has gentle bristles.
Hmm.
And then, I usually, when you come in office, I ask mom and dad, what kind of toothpaste do you use? People make conscientious decisions for themselves. And if they're like, we don't use Crest, we use Colgate, they're using a fluoride toothpaste. And I say, well, I think littles should do what their grown-ups do.
Hmm.
And so if you use Crest or Colgate, you should use a grain of rice of that same toothpaste or a kid flavored version, but it should have fluoride in it,
Hmm.
but a smaller amount of that medicine, a grain
Hmm.
of rice. And you should brush your little one's teeth before bed at the very least, and then we'll start coaching up to twice a day when they're ready.
Right. And I presume, like you mentioned on the parent side, get to know your child's mouth. I presume that's also getting the baby ready of like, hey, at some point we'll be in here
Yeah.
and we'll be doing stuff and it won't be like this big thing we have to get used to.
Exactly, because if you take your finger in and rub it over your baby's gums once a day and you make eye contact, you are meaningfully interacting with
Mhm.
your baby. It is purposeful play, and they're going to look forward to it. If you spend the entire first year of their life avoiding their oral cavity unless they're choking on something, they're suddenly going to be like, what are you doing in here?
It's a different association. Yeah, for
Totally different.
sure. For
So
sure.
it helps both parties feel really good about it.
Okay, awesome. Um, all right. So we talked about, oh, and did you say like when are we doing this first dentist?
Oh, yes. Okay.
Hopefully, when are we doing this?
Yeah. Okay. So a first dental visit should occur between the first tooth and the first birthday. And that first tooth typically shows up around 6 months. And I say around 6 months because the bell curve is kind of wide. Like my children didn't get their first teeth until they were like 10 and 11 months old. And there's absolutely nothing wrong with a very late bloomer with teeth. It's actually kind of helpful. It's just they're not going to bite you if you're nursing. Like,
I've been there.
right? And so it's one of those things. I tell you the 6 months, but I want you to know, please do not worry if that's just not the textbook your baby read.
Right.
And so between first tooth and first birthday means that I can sit down and spend 30 minutes with you and we can talk about how to brush baby's teeth with what you may choose, what modifications to diet you're going to be looking forward to in the next 3 months, 6 months, 9 months. I might check in on how intro to solids is going and what techniques and philosophies you chose for your baby and how to make them work better for you. I'm going to chat with you about milk transitions. This might be a transition from formula to cow's milk. It might be a transition from daytime nursing to cow's milk and continued other nursing times. It might be a conversation. I'm a big supporter of extended nursing, and I want to make sure that families are empowered to do so without compromising any dental health. So we cover a lot during that
Yeah, and
appointment.
that I think that's just another thing that sets you, maybe some others, apart. That's the education piece, the taking the time, it's just, I mean, we've all been to the dentist. It doesn't usually go that way.
No, and if you do a really good job the first time, it's not always going to be very lengthy because a 2.5-year-old for a 30-minute visit, that's stressful for families.
Yeah.
I want to do it while they're still like happy to sit on mom's lap and we can sit and chat and just like set up great groundwork. But the other thing that I really hope to offer my families is I know pediatricians have to cover so much during all of those well visits.
Yeah.
And I am hoping to offer them the support that if they had something touched on and had more questions or they needed someone to spend more time on it, I can be that space. I can be that support.
It's so beautiful. All right. So that's as much touching on just like general oral care that we're going to do today.
It's
So
all good.
let's get to the issues, right? That was all pretty positive. What issues do parents need to have on their radar, and what are the red flags that would signal like maybe we need someone to explore this?
Yeah. I guess how young do you want to go into like newborn? Do you want to
Go
go
for it.
that low?
Yeah, let's go that low.
Yeah, let's go. Okay. So there is a good part of my practice, which is supporting that newborn parent dyad where feeding is
Mhm.
really their biggest concern. There's no teeth typically in a newborn. And so, 10 years ago, that might have been almost exclusively someone trying to breastfeed and the latch is poor and they look under the tongue and they find a tongue tie. And so like, that's where it really originated from.
Right.
Um, my practice is looking at it, man, hand in hand with so many brilliant therapists, and I've learned a lot in this space, but it is still fundamentally support for anatomy. So sometimes anatomy isn't letting us do what we are meant to do, and that is we're supposed to feed. We might feed on a breast, we might feed on a bottle, but we should be able to do so efficiently, comfortably, without tremendous gulps of air and gas that makes the belly hurt or the milk come right back up. And so I spend a lot of time with those little babies and families that are navigating that. So things to look for that I would not expect to look for. Like I think everybody knows breastfeeding is a hard thing, right?
Right.
And I
Even
think
if
that the
there's nothing going on with the anatomy.
breastfeeding is hard. It's totally hard. And I think that, you know, most people notice tongue ties can sometimes contribute to it. And I think that it's seen in hospitals. I don't see a lot of babies coming into my practice that are tongue tied all the way to the tip of their tongue, can't stick their tongues out of their mouth. I think the hospitals are doing a much better job of screening these things. And
Right.
our pediatricians are noticing that and helping those babies access the help they need. Um, and so I'm going to mention the ones that trickle through that
Mm-hmm.
that are interesting to me and are
Yeah.
often missed. So babies that I see that are often missed. Um, a good example is, and breastfeeding is hard. We will see a good number of babies at the 3-week-old mark. And this baby parent combo, the mom will describe often, this baby is never satisfied. They are
Mm.
starving. They're always hungry. And so during a visit, they will sit and they might actually nurse them once or twice just over the course of my consult, which is only 30 minutes. Which, when I say only 30 minutes, that's actually a really long consult.
Right.
um,
But
but
it's
like,
pretty close together to have eaten twice.
right? And so you'll see them And you'll see a baby that loves to nurse, that snuggles into mom, is happy, is coming close, and is opening their mouth, but it's like they're sipping. And
Mm,
so you will hear gulps of air sometimes, but you might just see them just like opening their mouth, leaning in, and then sitting back up or falling asleep on the breast.
mm,
And these are babies that are not transferring.
mhm,
And mom is a very lucky person because she's an oversupply mom, right? I always tell them, like, if you were in prehistoric times, you would have made it and I would not, because I was a low supply mom.
Right.
You're a high supply mom. And it's such a wonderful blessing because as long as there's milk, it's a little bit easier for you. Like you can
Right.
make this work. It's just going to need a little bit of attention. And then you look at this baby, and what you realize was they were not latched. They
Mm,
opened their mouth and received what was available. And that strong letdown is really what's keeping them going. And this mom who is very willing to accept that breastfeeding is hard. And so
mm,
it didn't occur to them that they weren't supposed to do it every 30 minutes or
right.
every hour.
No, and there's
Um,
the whole the concept of like, nurse on demand or on cue or however you want to phrase that.
right,
So you can take that to an extreme of like, okay, well, my baby wants it every 30 minutes.
right. And so, and we're just told it's so hard, and we want to
Mhm,
do hard things for our babies. We don't want to think that we're putting ourselves first. And so I see people just try really, really hard and not realize those things. So that's over time, there's cluster feeding times when that's actually normal.
yes.
But it's not normal all the time. And then
Okay.
you'll get a weight check where baby doesn't follow their own growth curve. That's a
Mhm,
that's a good example of who I see
mhm,
pretty often.
right.
And when we go in and I do a full body exam, so I lay the baby down between me and the parents, and I take their head in my hands, and I'm going to feel the shape of their head because I am looking for a baby who might have some flattening starting because they're
Mhm,
habitually going to one side. And then I'm going to give them a little neck massage, and I'm going to feel how the muscles of the neck and the back feel. And
mhm,
sometimes I feel one-sided tension. Sometimes their necks feel like my neck. And a dentist neck is a bad neck because we're always like this and really tense. But babies should not feel like that. But sometimes they do. And I'm going to run my hands down their sides and just look at how their hips turn. And sometimes what I notice is that there are asymmetries.
mm,
And this is good screening, not diagnosis. This is not my scope of practice.
right.
Really, right? Like right here, this is my
Right.
scope of practice. Um, but it is good to be able to notice when asymmetries exist and help connect people to those that can help them with it. Then I work my way in and I go around in the mouth and I'm feeling for tension in the cheeks, the shape of the upper arch. And the shape of the upper arch really varies among babies. Sometimes I call it a vaulted cathedral ceiling. Sometimes it feels like a little bubble where you could hide your finger up there. And sometimes it's broad and you're like, yeah, this is the way it's supposed to be. And you'll feel muscle tension because depending on the muscles that are working, the ones working get big. And for all babies feeding, the muscle that's supposed to be working is the tongue.
Mm,
And so the tongue should be big. And babies who can't use their tongue for some reason, the cheeks get big, the
mm,
lips get big, because that's all that's left. You must feed somehow. So you feed around, you feel around, and you learn like, all right, well, how is this baby functioning? How are they compensating? How are
mhm,
they making all of this work? And then you go in and you lift up the tongue. And these are the babies that I typically see, and it looks like the Eiffel Tower under there, right? It's not all the way to the tip of the tongue, but when you lift it up such that it should suction to the roof of the mouth, you look at it and you're like, ooh, it's pulling tightly on that lower gum. And the family inevitably tells me, nobody told me they had a tongue tie. And I go, but did anybody put their fingers in? And they'll
right.
go, no. And I'm like,
They
well,
peeked with
then
their eyes.
yeah. And that's
Yeah.
fine. If that's, you don't want to just say based on, oh, you're struggling, your baby has a tongue tie, because I would never say that.
Right.
But you do want to put two fingers in and peek. And so there's no reason everybody who has a baby shouldn't feel comfortable going ahead and
Yeah.
checking that
But
out
you also
because
have something
that's,
to compare, have to have something like experience to compare it to. Like,
yep,
this doesn't feel like the other ones I've felt, and therefore,
exactly.
whereas like even if I stick my hands in my kid's mouth,
Yep.
I don't know what I'm feeling
Oh, yeah,
for,
yes,
right?
yes. Yeah. No,
Yeah.
but the idea is like sticking your fingers in gives you the ability, right?
Yeah.
And if you don't, you
Exactly.
can't really look for all of the types of ties that are there. So
Yeah.
I always land there. And then, I show the parent that I'm not going to pull right out of the mouth, and I put my finger up on the roof of the mouth and show the baby sucking just like they might on a nipple or a pacifier to soothe them down, and hand them back and say, sorry, I know Dr. Maria is super annoying. And we get the baby to settle right back down, and they always settle right back down. That's a really good red flag example,
Yeah.
riding the letdown.
And
Another
let me interrupt you for 1 second, because I never know what people know and what people don't know. One thing I wanted to go back to is that the mechanics of feeding, whether it's breast or
Yes.
bottle, but even particularly breast, are so complicated that if
Oh
you
my
haven't
goodness,
really
they are.
studied that or seen how the milk transfers and what's involved with the transfer, and like, radiography or whatever, it really is like, when you see it, you're like, wow, I'm surprised it ever works at all, because there's
Right?
so many so many moving parts.
This extremely
And
complex motion of the
yeah,
tongue.
and all
Tongue
we
has to
think of
go
is
up
like
and
the lips
seal,
go
and then it
on.
like dances.
It does this, yes, this like undulating dance thing. But it's not just like you might think, oh, it's their lips or whatever. But yeah, it's the lips, it's the tongue, it's the cheeks. And so I think, you can correct me if I'm wrong, the reason that a lot of um, tethered tissue, or as they're sometimes called, or ties, do get missed is probably the not feeling inside, but also it isn't always obvious in the front or to the eye, because there can be, most people are checking for the tongue ties in the front, but it can be all the way in the back. It can be the
Yep,
cheeks. It can be the lips. So there's just
absolutely.
a lot more to it. Um,
And my favorite example is, and sometimes it's not the tongue at all.
and it could be the palate, which has
It could be the
nothing to do,
palate,
right?
or it can be all that stuff that I checked first. And,
Hmm.
a tongue tie is something that I treat surgically, right?
Hmm.
But sometimes our muscles are so tight that the next muscle downstream can't move to its
Right.
full motion. And so sometimes it's not a tongue tie at all. Sometimes it's just all these muscles were so tight, they were pulling, 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 and the tongue
Which
was
could
fine.
just be from gestation and delivery.
Yes,
Yeah.
that very natural thing that we're all talking about. Oh, birth is natural. Yes, but it's difficult
And
still,
it's hard on the body.
right? It's hard on my
Yeah.
body. It was hard on baby to be folded in half like a football in there until they
Right.
got out.
Right. Right. Right.
So
And I think it's
absolutely.
helpful for parents too. This does not always require a surgical intervention. I do want to come back to
Yes.
varying opinions on that later, but it could be something as simple as what? Chiropractor, craniopathy, PT.
Well, okay, this is a good example where I want to jump into a science statement. So, when looking at mommy baby dyads, there is an article out there, I think it came out of Boston, where over 60% of the babies, if they were given better feeding therapy assistance, did not need a procedure,
Mhm.
right? And I think that that's the important thing to come from, where many times you might identify anatomy that looks suspicious or looks like it's causing the problem, but help can often make it that that is not the case. And so that help, I usually recommend start with an IBCLC. Start with somebody who really understands the function of lactation, can help mom with milk supply and baby with latch. And you will see a good percentage of those babies that were suspected of tongue tie actually thrive and do really, really well.
And I
And
would stress that many IBCLCs will also support parents who haven't chosen to breastfeed or wanted
oh,
to and
yes.
aren't right now, or doing some sort
Yes.
of combo. Now you do have to find one that fits and fits the
Yeah.
situation, but they would be the sort of frontline person to look at all of this, regardless of how you're
Oh,
choosing to
yeah.
feed.
So that would and we'll come back to it, but that would be my second red flag baby. There's that bottle fed baby struggling, and
Mm-hmm.
IBCLCs are amazing, amazing support for that. Or infant, speech therapist might be my second one for there. Um, yeah, this is good. Man, I get on tangents for this so
I
easily.
know
Okay, so a,
we could go
a
forever.
percentage totally need just better help, better assistance. And then another percentage you look at and you're like, the anatomy doesn't seem to be the culprit. It seems to be the victim.
Mm.
An example of that is when I have full mobility of the tongue, but the cheeks are overactive and the lip always curls in when a baby is nursing. And you're like, it's all muscle. This is muscle pulling these things. And if we could just help these muscles calm down and get the right one coordinated to what it's supposed to do, you can see that change. And that takes somebody skilled putting hands in the mouth and systematically teaching the family how to teach the baby to suck. And I know that we are supposed to be born able to do these things, but sometimes we need help. Actually, most of the babies I see need help, but I only see babies struggling, right? So I have a subset,
We say that
right?
too. Yeah. We don't meet the
But
babies
like,
who are doing fine.
no, they're sleeping and everybody's happy and they're planning a
Yeah.
second child. Um, so there's so many times that they just don't need surgery. And one of the things that I did last month, because there was a big conversation about that, was looked at my numbers. And
Yeah.
so I looked at a quarter of data and I had done over 200 consults. I'd seen a lot of babies.
Sure.
And I only completed treatment on 35% of them.
Okay.
And there's so many reasons. So some of them were they just needed additional help. Some of them were they were data seeking. They wanted to know, could this be contributing? And that's something that I think is really important, that there are many ways to feed a baby. And I'm very supportive of you just feeding your baby to your own personal goals. And you can ask me, is there a tie? Is there functional? And I'm sure that I have many solutions for you on what you might need. And then
Right.
some babies did need a procedure.
Sure.
And I feel really good about those numbers. I think my numbers are much lower, maybe, than most providers because my goal is to be part of your team as
Right.
opposed to being your release provider.
Well, and let me jump in there. So when I'm sort of figuring this out as we go, so everyone join me for the ride.
Yes.
Doing the sleep stuff that I do get a lot of, new parents with very young babies, and they're trying to figure out, is this a sleep problem? Is this a feeding problem? Is it colic? What is it? Um, and I get very skeptical when they say, we saw someone and they said there's no tie, or we saw someone and they said there is a tie, but it doesn't need to be resolved. It's not, the main factor. What I hear you saying is that may be true, and maybe I should be less skeptical. But what I'm thinking I would change my language to is like, okay, and there's still maybe other interventions that are needed other than revising it and other support that you have in place so that they can still do whatever they're trying, the feeding, the sleeping, whatever the challenge
Yeah.
is. Like, I don't know if it's enough to say like, no, there isn't one, or no, there is one and it doesn't need to be revised. It's like, and what's the and, right? But
Yeah.
not everyone is as informed as you. So they're not gonna, maybe the provider doesn't suggest anything else.
Well, I think also I am very hesitant to recommend a treatment if I don't think the outcome is going to be measurable improvement.
Mm-hmm.
Right? So, a good example, I will not recommend a frenectomy if the baby is not therapeutically prepared, if they haven't done some suck training,
Mm-hmm.
because I know that if I release that tongue, but the baby isn't already trying to stick their tongue out, trying to suction the tongue up, it's really hard to learn new skills when something hurts.
Mm-hmm.
And so that immediate post-operative period, it does feel like a pizza burn underneath the tongue. It truly is uncomfortable. And so we have a lot of the times when you see, oh, frenectomy didn't serve baby, you didn't get the outcomes you were seeking. And then you go, well, what was happening around it? That baby might not have been therapeutically prepared.
And then there's
Um,
post
Oh,
therapeutic
yes, there
steps that
exactly. And
can be different.
post-therapy is so much more feasible when you were already confident before the baby had the procedure. You need to be confident putting your fingers in your baby's mouth before they have a surgical procedure because you're not going to suddenly jump in the day of post and be able to help your baby lift their tongue.
Right. And
Yeah,
if you have no idea what a frenectomy is, you're probably hearing this lingo, pizza burn, surgical procedure, and you're terrified and you're like, I'm turning this off. This is horrifying. So
fair,
can you
fair.
just briefly touch on,
Yes, thank
that
you. I
makes
so
it
appreciate that.
sound complicated, but what does it look like in real life? Like in office, out of office, how long does it take? Is it scissors? Is it laser? What in the world are we talking about?
Perfect. Okay, let's open the lid off the black box.
Because
Okay.
I know that everybody else may not know.
Yes. So a tongue tie is when you have a little bit, it's not skin, it's mucosa, but let's call it skin for the purpose of it's covering. It's like an outside surface. So it's a little bit of skin underneath your tongue. And when you lift it up, it's not stretchy, right? It has a limit to where it can stretch. as opposed to other parts of our body, which if you stretch them and stretch them and stretch them, they will change shape. So it's something that will not modify with stretch. People always ask me, are you going to outgrow it? No, you don't outgrow it. It is the size it's going to be. And so if this piece that is not stretchy prevents the tongue from doing basically what it's supposed to do, your tongue should be able to stick out as you get older and be able to lick an ice cream cone. Your tongue should be able to suction up on the roof of your mouth. You should be able to make clicking sound, right? And you should be able to open your mouth pretty wide when doing so. Your tongue should comfortably sit up on the roof of your mouth. And if this little band of tissue keeps the tongue down low, these are basic functions of the tongue that you're going to have to compensate for. Find some other way to do the things that it would do. In my office, the way I treat this in a newborn, in an infant, is we wrap them up in a swaddle. We use a little bit of numbing gel underneath the tongue. Numbing gel is a variable. Not all providers use numbing gel. But again, coming from that academic environment, I know that pediatric pain is chronically underdiagnosed and underaddressed. And so I feel that we are doing the right thing addressing it proactively. So a little numbing gel
It
that is
has to
safe.
make the parents feel so much better.
I mean, it
Like
certainly
maybe it's
helps me
even for the
sleep at
parents,
night.
right?
Um, and
Look, I
yeah,
would want the numbing gel, okay, for myself.
want the numbing gel. And there are some times when a child cannot have a numbing gel because of a family history. And I do notice the difference. So I know I am helping a child be less distressed by using a little bit of numbing. And then I, on infants, use a CO2 carbon dioxide laser. But I do not stand by there is one instrument, one way.
Okay.
Because on older children, I use a scissor sometimes. But it takes me 30 minutes on an older child. And I don't think that anybody wants an infant having a 30-minute procedure. So and as far as the laser, it is a way that I can very precisely touch and release that extra skin there. It lets me control bleeding. It guarantees a very little amount of heat felt by the baby because it's a laser. And there are lasers out there that are very, very hot. And this one is not very, very hot.
Right.
And it's very fast. So it serves a lot of things that we need for babies specifically. So I really think that it's a great instrument for babies.
Wonderful.
And when the procedure takes me, when the baby is stabilized, a minute or two. It's really brief. It's so brief. And then we pick baby up because I don't think any baby should be just like not comforted.
You lay there and recover. We'll be back with you.
Yeah, exactly. So you'll usually see me holding baby and I'm doing the mommy bounce, right? And the parents are like, they're so chill. And I'm like, if I stop bouncing, they're gonna miss you. Here you go.
Right.
And so one thing that I notice in my practice is because I don't have those tied to the tip babies that are 1 week old, I'm typically seeing like a little bit older. I don't have babies going straight to latch after nursing most of the time. And it's just something that I always tell families, I want to adjust expectations on this because this idea that this is hitting it out of the park, quick fix is just not fair to you. So some babies will want to latch because they find that so comforting. And I always make a space for that and encourage the families to do so. But some babies are like, could you just hold me, please? And I'm going to take a really long nap. And I encourage families, like, let them take their nap. This nap is normal. This is what happens after you do something hard. And this was not, and then they rest and then they wake up and they'll do their first feed.
And I've heard parents say this makes a huge difference right away. Feeding, growth, mood, fussiness. I think it's also fair to say, like you just said, every baby responds differently. And sometimes the recovery feels a little harder. Sometimes they're more bothered by the, post-procedure exercises, and it will still get you to that, much better place, but it may not be as magical or quick. Is that fair?
Right. Yeah. Okay. And I feel that seeing how a baby does like with their prehab therapy, you get a good idea of who's going to snap in really quickly and who's going to need a whole lot of TLC. Right.
So you're also helping parents maybe set their expectations for their particular baby.
And get the help that they need for it, because I am not an advocate of DIY. It's just hard. Like, nobody was born knowing how to lift this baby's tongue, teach the baby to suck. This isn't something very easy. And there are really skilled professionals in our community. And so sometimes in the last year, I've had this interesting experience where I will get a parent who it's their second or third baby. And they're like, I know it's a tie. My first one was tied. We had it released. And I will proceed with the release without saying, okay, we'll go see the therapist first. Cause they're like, I know how to do the exercises. They're convinced, they're very confident.
Yes.
And what I do, this is something I do differently from a lot of providers, is I do a lot of post-oping. And I do it to support a family because I don't want anybody struggling when I could have just helped. So I do a 1-day post-op. Well, okay, so the first post-op I do is the evening. I send a text and I'm like, how are you doing? And I just want them to have a warm line because that's the time, usually at 3 a.m., you're like, I have a question. And I tell them, like, if you send it at 3 a.m., I'm not going to see it, but I will see it first thing in the morning. But that warm line is where I get the short-term feedback of how baby feels. So most babies immediately post-op, they sleep, they take a good long nap, and their first feed, they're a little bit hungrier. And as long as they're on the Tylenol, they say they were a little fussy, but they're otherwise fine. And I feel really good knowing this information as
Right.
opposed to wondering.
So you can sleep.
Yes, exactly, exactly. Then you get babies with the 1-day post-op. And the 1-day post-op, I always say families, there's some wound care. You have to lift the tongue, and you're going to do it approximately every 4 hours. And there's no strong science behind this every 4 hours.
Okay.
Every 4 hours, I am saying is reflected on likelihood of adherence. So if I asked you to do it every 2 hours, you might actually have a little bit better of outcomes, but when will you sleep?
Mm-hmm.
Right? And your baby needs to sleep and you need to sleep. Whereas every 4 hours follows a lot of everybody's wake windows.
Mm-hmm.
And it feels like I can ask it and also get it. And so that's a little bit of motivational interviewing and behavioral intervention. I want to do something that when you come back to me, you don't feel shame saying you couldn't do.
Right. Right.
So that's why I say every 4 hours. And it's a plus or minus. Like if they
Yeah.
wake up at a 3-hour mark, you don't wait an hour, put them to sleep and wake them up. Like, okay, 3 hours is good. And if
Right.
they're like, if you are in the middle of the night and you are out cold and your baby's out cold and it's a 4-hour mark, like hit the snooze for another 30 minutes and
Yeah.
reevaluate it. And that's also
Okay.
fine.
Awesome.
So I do that 1-day post-op and I say, I want you to do the wound care a couple times on your own without me watching, and then come in and let me help you. Let me coach you through a round. That way you do your flail on your own and you figure out what's hard and what you need help with. And then I can be meaningful help. So I really do like doing that 1-day post-op. I will sometimes share it. So if somebody is coming from 2 hours away, and yes, I've definitely had some families come from 2 hours away, and they have a local therapist that can help me with that, I'm going to do that because I don't want people putting their babies in the car unnecessarily.
Right.
But I want you to have hands-on help 1
Yeah.
day post-op or 2 days post-op so that when you do something every 4 hours, you are confident you're doing it well.
Right.
And then I do a 1-week post-op. And the 1-week post-op lets me ask how it changed things. And what I see is a good proportion of babies are having meaningful functional differences at the 1-week mark. And now I can adjust the wound care afterwards. I can take a picture. I can see what my own surgical outcomes look like. And I think that is very vulnerable, right? I need to be very clear with my measurable outcomes. And by asking you, like, we're being clear on what really works and what
Yeah.
doesn't.
Well, and
And
I mean, I don't imagine, I know if they're eating better, getting more, not having to
oh,
work
yeah.
so hard to do it, they are more pleasant, like calmer, not as
Oh, my
fussy,
goodness.
happier.
Life
And they
altering.
can sleep better, assuming
Yes.
that the sleep
Hungry
and
babies don't
everything
sleep.
is tied together. Right.
Yeah,
And
hungry babies. Yeah.
exhausted people don't sleep particularly soundly. So I feel like if they're spending just so much energy and effort on a process that should be fairly seamless, you know, we're all fussy when we're working too hard and not getting much from it.
Absolutely. And at that 1-week mark, I also now have enough time to say, do we need to adjust the help you have?
Mhm.
Because I don't want to discover that a month later.
Right.
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 And that's what I found with those sprinkling of families with second babies with frenectomies that were like, I got this. Then
Right.
I would see them at the postmark and I'd be like, you're doing it. You're doing the wound care, but you're not having the outcome I wanted you to have.
Right.
Right? And they didn't know that that was an end game. They were like,
Right.
oh, well, this is how it ended with my first one. I'm like, there's more for you. We can
Right.
do better.
Right.
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 And if you don't see them at that 1 week mark, or, and these, I'm also a little unique. I'm not a tongue tie practice. I am a
Mhm.
comprehensive pediatric dentistry practice. So I
Mhm.
also get to see these babies at 1 year, 2
Mhm.
years. I see them progress over the years. So I get a lot of good follow up, and this is data. This is
It sounds
good
like
info.
all figured out. So I want to shift a little. We've so far talked about
Yes.
babies and feeding and tethered to shoes. For what I do, I'm seeing a lot of 2, 3, 4 year olds and up who, they're eating just fine. Maybe there was a tongue tie revised in the past. Maybe they spotted one and decided it wasn't disrupting feeding, so no need to do anything about it. And now they are not sleeping particularly well. And of course, in the threes, I think you can correct me on that, is also when things are growing and changing,
Oh
tonsils,
yeah.
adenoids becoming enlarged. So if we're speaking about the older airway, I believe it's less about ties and more about the palate and other pieces of anatomy. So can you speak a little to preschoolers and their airway
Yes.
and how, even if we can't see anything with our eyes, um, how can it affect their sleep?
Yes. Oh my goodness. I
That's like a
love.
whole nother one, right?
Yes. I will run away with this one, so you just keep me on
Okay.
topic with it. All right. So sleep is so essential. I think that we put all this energy into vitamins and nutrition, and I don't think that we have enough value for how important sleep is for that developing brain, and also what the variations in normal sleep look like. But a preschooler who is showing signs that they're not getting enough sleep. So that might be a child
Especially if
who,
you can see that they are in terms of the
right,
number of
like they're
hours.
in the bed, their
Right.
eyes are closed, but they wake up. They are a super grumpy monkey
Yes.
most of the time. And they're having consistent and regular, if not constant, meltdowns. They're just
Their
brittle.
behavior is, yes.
Yes. Um, they look tired
I
under
was
their
going to
little
say a
eyes,
lot
that
of parents
shiner,
report, yes.
right? Um, Here's one. Sometimes not a 3-year-old, not a 4-year-old, because it still falls within range of normal, but as children get a little bit older, they're still bedwetting, right?
Hmm.
And you go, their dad was like this and their family, it's normal, but like they're 7 and they're still struggling to make it through the night dry for one reason. Or they're not bedwetting, but they wake up 2 or 3 times a night to pee.
Hmm.
That's just the other side of the same coin,
Hmm.
where they're not concentrating urine,
Hmm.
and as a result, having this problem.
Hmm.
If they're snoring, there is no such thing as a healthy child snoring. They might have a cold and then they're sick and then they're snoring,
Right.
but if they are,
Say that one more time, really
there
slow.
is no such thing as a healthy child snoring.
Thank you. I just wanted to soak in to everybody.
Yeah.
Now, if they're congested and this is
Well, they're sick. They have a
isolated,
cold,
right? You're
right?
talking about all is well. This is just how they sound when they sleep.
Right. Yes. And this is a very personal story for me. This is child number 2. My child, who is running, jumping, playing, lovely personality, turned into a meltdown kid,
Mm.
turned into a morning grumpy monkey. And because I'm a data person, I realized that my 3-year-old had not slept the night in 9 months.
Ooh.
It just like, I was like, how did I get to this being my normal that my child wakes up once to twice a night? And not that I expected her to be nighttime trained, but she was never waking up with a dry diaper. She was always waking up, and often waking up soaking her diaper and needing to be changed.
Mm.
And when she would sit there in color, she would sound like Darth Vader.
Mm.
But
Well,
she
now,
wasn't,
which is different from snoring. We would
it was when
typically
she was
call that
awake.
mouth breathing.
She was mouth breathing, but like you could hear it.
Right.
You could hear
Noisy
it.
breathing.
Hmm. And when she would sleep, she would close her mouth, right? So it wasn't checking off this mouth breathing thing, but she had this low level grumble snore. And it just wasn't checking anybody's alarm boxes but mine. And so I tried to be patient. I tried to not be alarmist. And I asked the experts, and nobody was really checking off any boxes, but I was watching her grow. And she started being at rest with her mouth open at all times. She had a little bit of speech issues that I was able to prompt. And then you go back in time, she also was my difficult nurser. She never really thrived in that space. It was a heavy lift for me. And her arch started narrowing. She started becoming a child. So I have two children side by side. I have one who has like beautiful wide spaces between all of his teeth. And then my daughter, all of her spaces started closing. And I
It's
was
the
like,
cathedral, right?
yeah, yeah. I was like, wait a second. You two are genetically the same people. What is happening here? And then I, did what I do as a parent, and I'm feeling up in the roof of her mouth, and she has a cathedral ceiling. My son does not. And finally, the stars aligned, and being the child of a dentist, you don't get regular dental visits, right? You have to come in when you can like make it work. And I have her come in with my husband. I go, I need an x-ray on this child, on my 3-year-old. And I took a plain film of the side of her head. It's called a cephalometric radiograph. It's commonly taken in orthodontics. And my daughter had the largest adenoids I have ever seen.
And you could see
Taking
them on
that
this.
film. I mean, you could see it from across the room. It was alarming. But she didn't sound the way every ENT or pediatrician would expect her to. She didn't look to them, but to me, she did. And this is where the power of a dentist in screening sleep disordered breathing comes in. And so, take you a little bit back in time, why I even started noticing this. In 2017, our professional organization threw out a very quiet guideline saying that all dentists should be able to screen for sleep disordered breathing. 2017, they're just like, here, start doing this thing with no training in the general profession.
Sounds like a great idea.
Fabulous idea.
I mean, I guess knowing is half the, like having a goal is half the battle.
Right. Yep. And so if you were paying attention, you started asking the questions of, is your child snoring? Are they grinding their teeth at night? Are they sleeping the night? Are they bedwetting? Is your child on ADHD medications? Right? And these are questions that trigger more questions. So a lot of people are very nervous about even stepping on this, even starting this, because you ask a question and then you get a yes answer. Well, what do you do now?
So it's
You refer. That's what they tell them to do. You're supposed to refer. Refer to whom exactly? The pediatrician, perhaps? An ENT, perhaps? A sleep center that has a 1 hour or 1 year wait list, perhaps? I mean, it's terrifying. It's a black hole.
Those are our options here.
Those are our options.
Yeah.
So I said, okay, this is a big ask. I want to do well by my patients, but you can't just give me this list. So I started learning more. I'm reading and I'm taking well-curated continuing education on it. And I go, okay, all right. I understand the whys of each of these questions now. I am by no means a sleep physician, but I have better understanding of sleep architecture and where it fits in. I have better understanding of the neurotransmitters and the pathways that lead to grinding teeth being a symptom, a better understanding of like when REM cycles kick in and what that does for childhood development when it looks like they're sleeping, but they don't stay in REM long enough.
So it's the quality that becomes compromised, which is why they could get the right quantity and still behave like they're very underslept and look
exactly. And they might not grow because REM is when growth hormone is secreted, and REM is when antidiuretic hormone is secreted, and that's why the bedwetting happens.
I was going to ask you to tie that together for us. So thank
you. No, like I needed answers because you can't ask me to screen for something and alarm families about it and then be like, but I don't know what to tell you to do about it.
It's just a question I have to ask, right?
Just a question, check. So I found that these were far more powerful questions now because I was like, okay, I see it. And then I had an important question from my colleague next door who's a pediatrician. She goes, I hear you talking about these things a lot. What can we, I mean, what are you going to do about it?
Right.
That's a really good point. So off
You're like,
to,
I haven't gotten that far yet.
right. Off to more CE I go. And I am a part of the team. I like to describe it like I'm part of the pie. I am not the principal member of this pie, but I am a part of the team. And so for littles, my screening is similar to yours. It's making sure that there isn't an obstruction. Are allergies going untreated, for instance? And I think this is
A
a
big
big
one.
one because philosophically, we came from a generation where the idea was less medicine is better, right? And I'm not really sure that I disagree with that. Less medicine, probably, like you don't want to just throw a
Just
chemical on it,
medicate. Yeah.
right? There's behavior things with that. There's keeping pets out of beds and taking care of dust and filters and things like that. But I live in the city, and this is a
So good
very
luck with that.
dusty,
Yes.
moldy, allergen infused space. And if I were to subscribe to the less is more philosophy, you end up with big tonsils and adenoids and inflamed mucosa of the nose and a child who just can't breathe through their nose. So, one of the most helpful things that I think I do is I ask, has your pediatrician had any conversations with you about allergy control? And actually, what I found is most children have. And the families chose not to implement because they did not. It's called developing discrepancy in terms of saying, yes, I want to do an intervention, or no, I do not. They didn't see enough benefit to their child to give them the medicine. They were like, oh, it's not that big a deal. I had allergies as a kid. My eyes were itchy. I moved on and I'm fine. And I go, okay, this is helpful. You already had somebody, a health provider, who said it, and I am simply echoing their message with another why. And the why I can give you is a good dental why. And every single patient I see, I do a screener for sleep disordered breathing. And this is far more useful than asking you those sleep questions. I'm going to actually look at your child and show you the things that have been happening long term and are trending and are showing you this might be more of a chronic problem worth taking that allergy medicine that you were already told to do. And, when I run through it's, are they breathing through their mouth enough that when you look at them, and I have TV screens in my office on the ceiling, so the kids are usually sitting in the chair looking up. And if during the time I'm chatting with the parents, they're like,
You're watching.
I'm like,
Right.
have you noticed that your
Right.
child breathes through their mouth most of the time?
And it's
There's
easy
something,
for a parent to think that it's like a quirk or whatever, like, oh, but all those things that kids are doing, they're trying, like you said, to compensate.
yes,
So the tilt up of the head and the open of the mouth it's like, how can I maximize airflow because it isn't
yeah,
working the standard way?
exactly. And bringing attention to these variations, right?
Right.
So are they mouth breathing? There's something called mentalis strain. It's overactivation of this muscle. So when we are struggling to move tongue, still tongue tie conversations, it's a degree of separation now. We find other ways to close our mouth. And one of
Mm-hmm.
them is using this muscle to pull the lips
Mm-hmm.
up. So,
Mm-hmm.
or it might look like lip sucking. Lots of kids lip suck. So mentalis strain is one of them. It's a chronic compensation. Tonsil size. So if a kiddo opens up their mouth, you go, and look all the way in the back of the throat. And those tonsils are greater than half of that throat space. They're enlarged.
Mm-hmm.
And this is a pretty common finding.
Right.
Okay. But if they're so large that they're kissing, that means that as soon as they fall asleep, the muscles back here relax and this no longer tense open, but falls back.
Mm-hmm.
Those kids have to be snoring. There's just
Right.
nowhere for the air to pass through. But if you look in the back and they're snoring and you don't see those tonsils, it can still be those adenoids. And this is a
Right.
group that I found I was really helpful for because that x-ray I took on my daughter was really good at finding that and handing it to my colleagues, ear, nose, and throat physicians and saying,
Mm-hmm.
I can see these enlarged adenoids. You can use this information.
Right.
Hand it right on over.
Got it.
Um, Tongue tie matters. Oh, how are we still talking about tongue tie? If you can't close your mouth and suction your tongue up on the roof of the mouth, it falls open most of the time. And if it's open most of the time, you are now irritating the living daylights out of your tonsils, and that will contribute to inflaming them. You are also not growing the roof of your mouth, that bone there. That bone is not all genetic. That bone is grown by your tongue. And if the tongue is low, that bone stays narrow and will not
And
be
you're
as
not
big.
filtering. There's a whole filtration system built in through nose
Huge
breathing.
filtration system. Like the air you breathe
Yeah.
through your nose and the air you breathe through your mouth is totally different to your lungs.
Right.
It
So
is
it's not like just a
humidified.
preference that our kids are mouth breathing and something
No.
we can be like, okay, that's you. You do
Yeah,
you.
no. It is a completely different survival mechanism. And,
Right.
we use that air differently if it came through our nose than if it came through our mouth. Yeah,
Okay.
absolutely.
Awesome.
So tongue tie has that one. And then, whether they grind their teeth or actually look narrow. If you look narrow, it means you've been breathing through your mouth so long that it changed your face.
Change the shape. Yeah.
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 So that's where dental comes in. And now I
Right.
can be useful
And that's why I
because,
get a little skeptical when I hear a parent say, like, there was a tongue tie, it was spotted, it didn't affect feeding, done.
right.
And now they're coming to me with sleep challenges. I'm kind of like, I want someone to take a peek again because that's great that feeding went well, but that doesn't mean it's not causing a problem in a different area. And that person was
Hmm.
probably looking solely at how feeding was functioning because it was maybe too early to expect any kind of sleep norms or, goals or
Right.
anything like that.
Well, I also find if we ask deeper questions, sometimes when they say it didn't affect feeding, the baby was gaining weight
Mm,
and it didn't affect weight gain. But
right.
if you had looked at feeding, you would have seen a baby who was feeding and riding that letdown by
Right.
feeding
And mom's
frequently,
uncomfortable or in pain or
clicking. That baby might have been on reflux medicine because they were gulping air and then refluxing it up. They might
right,
have been called the colicky baby because they were gassy all the time.
right,
Or mom might have said, we did breastfeed, but I stopped at 3 months, and it was actually because their milk supply plummeted because the baby was so happy for 3 months. And then, because they weren't latching
right.
effectively, the milk dried up. So
Got it.
they fed well is often something that I dance around carefully because I never want to
Mhm.
distress a parent. That's a
Right,
memory time. But
right,
sometimes there are the right questions you ask, and you're like, oh, there were compensations. You made it work. You worked really hard at it.
right,
But they weren't feeding ideally. You just
right,
made it happen because
right.
you're a super parent.
Because you're a badass. So let me ask you this. This sounds a little complicated, definitely
Yeah.
specialized. So just to clarify, it's not like every, or is it? Is it every pediatric dentist can spot this, ask those deep questions, or are we, if our gut is pinging, we're really looking for someone that's decided like you did, I'm making this kind of part of my thing and I'm going to learn all there is to know
Yeah.
about it.
That's a great
Okay.
question. I think the answer is going to be different today versus 10 years.
Hmm.
Because it's hard to teach a whole cohort of people how to do something.
Right.
And human beings only change when we are moved to do so by some
Mhm.
really good reason. So for me, I was moved to do so because I had so many questions about the children that I was taking care of. And I kept seeing them plateau in their development and their behavior and the things that they needed. So I had to get more information. But if you're super busy and you're not necessarily an infant focused practice, I don't know that you're going to go out and get educated in those things. And
Right.
most doctors don't, expand out of the things they touch on when they're in residency. Like if you don't know to go seek it, why would you go ask it?
Right.
But I do find residents who are in their training programs currently, they reach out to me all the time and they want to know.
So in 10
And
years, your answer would be different,
yeah, I do believe in
which is
10
great.
years, you're going to find it much easier to get this information.
Excellent.
Um, but at the moment, a lot of the reasons that I went through and got the additional training I did was because I couldn't refer my babies to anybody. I couldn't
Right.
refer my preschoolers to I had nowhere to send them.
Right.
And so
Which is
I,
not ever okay with any of us.
no,
We want to, we need
horrible.
to get people where they need to be, or we need to become that resource.
Yes. So I was very fortunate having as much orthodontic growth and development training as I did in my residency. It was significantly above typical. And I said, okay, I am going to find the best, the experts in the industry, and I am going to put all of my energy into learning this as much as I can.
Fabulous.
So I am a part of that pie
Yeah.
now, and I'm really grateful for that.
And I think it helps parents to know. I mean, I know it sounds overwhelming, but you keep talking about the pie, and I would usually say a different version of that is like this may require a multidisciplinary approach,
Yes.
which parents are like, I want to go to one person. I want them to fix it. I want to be like done with it. And I totally get that.
Right.
But because this is so complicated and there's different lenses we need to look at it through, you really will probably need that sort of team
Yes.
approach to get really the best result and make sure nothing's overlooked. And that doesn't have to be incredibly time consuming or scary. I
And
have
it
two
doesn't have
last
to be all at
questions for you.
once.
Right. Yes. Right. One person can look and then we can kind of move them down the line. What if a parent is told that there's not an issue or the issue does not need to be addressed, but their gut is telling them otherwise? What would you say to that parent?
Well, I think anytime you have an opinion that doesn't settle your curiosity or your gut instinct, get a second opinion. And it's just important that when you get a second opinion, it is uh, accessing something you did not previously have.
Mm,
So I don't want you to select a second opinion and give yourself like, it's called confirmation bias. I'm
mhm,
not saying get a second opinion that's going to agree with you, but just make sure your second opinion has more knowledge.
mhm. Right.
Right? Because if you ask your next door neighbor and you disagree with what they say, and you just ask your other next door neighbor, but you're trying to decide if you're getting surgery, like, I don't know that those are an opinion and a second opinion.
Right.
It's good
Right.
crowdsourcing. It's good to like sound off your ideas, but you just need to make sure that your opinions are building your knowledge base.
Right.
And on my side, I do a lot of that for myself. There are
Mhm.
just times when I get asked a question and I go, I don't know,
Right.
but I know where to get you this
Right.
information.
I love that.
So
Awesome.
just
Okay.
expand your knowledge base when you get a second
For
opinion.
sure. All right. We're officially at my longest podcast so far. So
So
congratulations.
sorry.
Love it. But we will bring it to a close here. I will definitely have you back. For my last question, take
Yes.
your dentist hat off, all of your
Yes.
other academic hats. I want only your mom hat on, mom of two,
Mhm.
8 years into that journey. What is one thing you've learned on your own parenting journey, hopefully that we didn't touch on yet, that you
Yes.
wish you knew sooner, realized sooner, came to sooner, and you want other parents to know now?
Yes. Okay. I have this memory of intro to solids with my son where I like so proudly pureed zucchini and his first food was vegetable. And I thought I did it so well because I didn't do cereals like my mother said. And that when it came time to do intro to solids with my daughter, who is 4 years younger than my son, I take her to the pediatrician and I describe this. She says to me, it's a little old fashioned. And so the thing that I wish I knew is that it is going to change. The correct answer is going to change and be okay with that.
Mm,
Because sometimes it worked for us, and sometimes we find out that there was a better option. And only by being really open minded and listening, it's okay. It will
mm,
change.
yeah,
And sometimes things change for the better. Sometimes we're not sure that that change is for the better, but like every generation, we are all absolutely adoring, loving of our babies. And
mhm,
so we are all motivated by that. So when we're changing, we're just trying to do better.
yeah,
So I think that just embracing the fact that we did not know everything before, and I
yeah.
do not know the right answer yet that's coming.
Yeah. And when we know better, we can do better. Or
Yeah.
when we know more, we can do differently. I love that so much. Dr. Maria, you are always a fabulous guest. I will
Thank you.
definitely have you on again. Thank you so much for joining me. Listeners, I'll be back soon with more stuff that I and other parents wish we had learned sooner. In the meantime, I'll leave you with my list of stuff I learned the hardest way. It's always the same: accept help when it's offered, ask for it when it isn't. You're the expert on your child, so trust your gut. And if you need to, be the squeaky wheel. Thank you so much, everybody. We'll be back soon.
Thank you.